It's not so much that we're doing anything wrong. It's that what we have available doesn't cut it. So what I mean by that is the traditional way to manage acute pain, specifically postoperative pain, is to use the most widely used medications are opiates. So in surveys that have been done, 95% of the drugs that are used to control acute postoperative pain are opioid-based. And that's been done for many, many, many years. There is a general movement through the anesthesia and surgical community to what's known as enhanced recovery after surgery, or ERAS, and there are even national organizations that support this. Studies that show when you take into account all the things that you can do to improve recovery, be it social, psychosocial, using opioid-sparing approaches, using multimodal therapy, which is another way of saying opioid-sparing approaches, you can enhance recovery, reduce length of stay, reduce pain, and reduce chronic pain. And it's not so much so really what it comes down to is what can we do that's different. So we can do we can address acute pain with preoperative assessment and measures to preoperatively, intraoperatively, as well as acute postoperatively manage people's pain more aggressively. And there are things being done in the operating room every day or in outpatient surgical areas every day to do that. I would say that it's important for the providers to recognize that there are people, well-documented groups of individuals, people with certain body habits, lifestyle habits, smoking, other premorbid conditions, and it's very important to recognize those factors before the person undergoes treatment or surgical treatment, so that the most careful care can be given to preventing those morbidities from complicating the recovery. What's very interesting and what is coming out of Nobel Prize winning chemistry work is understanding that when a receptor is activated, so in this case the mu receptor, there are now ways, understanding that receptor, it's not just a little boat going into a dock, that imagine if the dock after the dock is activated, there are multiple other pathways on the land that would also be activated by the dock. And what if one boat coming in got into the dock space, but it wound up only activating the more desirable pathways downstream? It turns out when the mu receptor is activated, it downstream, depending upon the chemical that's activating it, can activate a pathway called the beta-arrestin pathway, which is what's responsible for most of the side effects, as well as pathways which are responsible for the good effects, the analgesic effects. And it's been understood for years that G protein specific agents can actually, or G protein signaling agents, can actually allow for a more selective downstream activation of the positive aspects of an opioid and minimizing the activity of the downstream pathways that you would not want to activate. So in other words, in plain language, you get the analgesia without activating the beta-arrestin pathway, which is where novel analgesics in this class are being developed. And so at the end of the day, there are many administrative and even other medical multimodal approaches to enhancing recovery after surgery, improving outcomes, but there are novel therapeutics that might take us to a whole new plateau. The excitement is based upon clinical trials that are being done. It's already been demonstrated in humans that one particular drug that's in development can accomplish the goals. In a study that looked at placebo, morphine, and 2 doses of the study drug, patients getting different drugs intravenously. Of course, the placebo group have the fewer side effects, but also they don't have the pain relief. there's equivalent amount of pain relief with either the study drug versus morphine, but the side effects are markedly reduced in the study drugs. So that's important. Maybe a new molecule after all.